Good evening, friends and colleagues. On behalf of the Education and Scientific Committees of BOFAS, it's my pleasure to welcome you once again to this evening's BOFAS Virtual Journal Club, which is, after all, the place to be on a Thursday night. Let's face it, pub, BOFAS Journal Club, BOFAS wins every time. This evening's topic is midfoot trauma, and the session will follow the same format as previous journal clubs. There are two papers to be discussed. The first is Chris Coetzee's paper on primary fusion versus open reduction and internal fixation for primarily ligamentous Alisdair Felstead injuries from 2006. The second, the systematic review of dorsal bridge plating versus transarticular fixation by our very own Jit Mangwani and his group. Each paper will be presented by a fellow, and then the senior author will share his reflections on his work. Finally, we will have a short question and answer session on each paper. I shall be moderating the first part of the evening, and my excellent colleague, Mr. Togay Koc, will moderate the second part. Before we begin, as always, I'd like to thank our sponsor, DJO, for their very generous support, without which events such as this would not be possible, and we'd all have to find some other forms of entertainment for a Thursday evening. So, the first paper. It is something of a cliche to say that the senior author needs no introduction, but in the case of Dr. Chris Coetzee, I have to say I think this really is true. Past president of AOFAS and a long-standing friend of BOFAS, Chris is an innovative foot and ankle surgeon, widely published, and a thoroughly good chap. So, without further ado, I'd like to ask Mr. Alisdair Felstead to present the first paper.
Hello, my name's Alisdair Felstead and I'm a foot and ankle fellow at Portsmouth University Hospitals Trust. I'm going to tell you about a study which looked at the treatment of ligamentous Lisfranc injuries with either primary arthrodesis or open reduction internal fixation. The background to this study is that open reduction internal fixation has generally been the accepted treatment for displaced Lisfranc injuries. But unfortunately, even with early diagnosis and treatment, the outcomes are not uniformly good. We've generally reserved arthrodesis for the more comminuted fractures or those that have been missed or suffered with a delayed diagnosis. There are some patients, however, in the open reduction internal fixation group which go on to develop painful osteoarthrosis despite optimum treatment. So this study sets out to look at what would be the optimum treatment for those patients with purely ligamentous Lisfranc injuries. Patients were split into two treatment arms. Half the patients went into the open reduction internal fixation group and half of them went into the arthrodesis group. The study's authors looked at functional outcome, radiological parameters and pain scores. This was a prospective randomized controlled trial and treatment was initiated within 1 month. There were 41 patients included in the study and the average follow-up was 42.5 months. There were some exclusions, which are listed below. Of note, any intra-articular fractures or patients with diabetes or other significant foot and ankle injury were excluded. Primarily, the medial 2 rays were addressed, but the 3rd ray was included if unstable on a CT scan. The 4th and 5th rays were also looked at on the scan, and if they were unstable, they were stabilized with K-wires in both treatment arms. Screw fixation was undertaken with 3.5 or 4mm screws. And then post-operatively, patients were stored on the AOFAS scale. Weight-bearing radiographs were taken at each clinic appointment. They were clinically examined and a visual analog pain scale was completed. Patients were split evenly between the two treatment arms. 20 patients were in the open reduction internal fixation group and 21 patients in the arthrodesis group. Of note, 16 out of the 20 patients in the open reduction internal fixation group had to undergo hardware removal, an average time of 6 months, 6.75 months. And 15 of the 20 patients showed a loss of correction or degenerative change in the joints. Indeed, 5 patients crossed the treatment arm and underwent arthrodesis as a secondary procedure. only 65% of the patients who had open reduction internal fixation achieved their pre-morbid activity level. And in the 21 patients in the arthrodesis group, 19 underwent uncomplicated fusion, 1 was revised and 1 was treated with a bone stimulator successfully. The average time to fusion was 10 weeks, and there was no difference in outcome whether 2 or 3 rays were fused. A much more impressive 92% return to play score was achieved at 2 years. So the conclusions from the study's authors are that open reduction internal fixation can often lead to persistent pain and osteoarthritis. This is generally been perceived to be due to poor ligamentous healing. It's therefore been proposed that primary arthrodesis might be a more suitable treatment option, and this may give better functional, radiological and pain score parameters postoperatively. Indeed, immediate arthrodesis rather than revision arthrodesis may be more effective treatment. There are some limitations to the study. The randomization method was done alternately, and this could have induced some bias. There was a lack of comparison with intraosseous fragmented injuries, and there was no information on the excluded patients. Also, a large proportion of the open reduction internal fixation group underwent hardware removal, which may confound the results. Thank you.
Thank you, Alisdair, for a succinct presentation of the paper. Before we go on, I should have come clean, as the more perceptive amongst you may realise the logistics of time zones have meant it impossible for Chris Coetzee to actually join us live this evening. He was, however, kind enough to record his reflections on his paper and then take some questions from me. So we'll now move on and hear Chris's reflections on his work.
Good evening or good afternoon, not sure exactly where you are. Mr. Ritchie asked me to give you a few perspectives of my study that was done in 2006 about Franc injuries. And this is a study about treatment of primarily ligamentous Franc injuries, fusion versus replacement. And just a bit of background, my mentor at the time was Dr. Hansen in Seattle. And he always said, you know, I know fusions work, somebody needs to go out and prove that. So when I started in practice, I decided to look into that. And my residents and I at the time presented this at the Academy meeting in 2005, not knowing that it's going to create quite a bit of a storm, which was fun in a way. We'll go through this quickly because you can obviously look at this at your leisure. So it was a prospective randomized study looking at fusion versus a replacement for a similar group of patients. And we excluded comminuted fractures because even now in my mind, those will do better with a fusion right off the bat. So there's no real debate about that. But this was about the ligamentous injuries, and you can extrapolate that to wherever you want. The procedure was exactly the same for both groups, prepared the injury, reduced the fracture, and then one group fusion with screws and the other group screws as well. And at the time it were transarticular screws mostly, and followed them at 2 weeks, 6 weeks, 3 and 6 months, and then annually, and did the examinations at those intervals, and also the clinical questionnaires and the AOFAS Midfield score. The demographics were about the same, and then if we look at the results, the fusion group did better at every interval. Even with a clinical questionnaire, you can read this at your leisure. The fusion group did statistically better than the open reduction group at every interval, same with the pain score. There obviously, like any paper that's that old, there are potential issues with it. One is, if I have to do it now, I will not use transarticular screws for the open reduction group. We'll use breech plating where you do not violate the articular cartilage. And the same with fusions. I might actually use plate combinations instead of just screws. But here's the problem really. this one in my mind is relatively easy. I think most of us will do an open reduction and internal fixation for this, not a fusion. Well, that's also easy. I think this one needs to be fused because they are intra-articular comminuted fractures. And if you think you can get a good open reduction, you will have problems at times. For me, this is where it becomes really complicated. And I wish I can predict how these cases will go. This is a typical longitudinal Lisfranc injury. So instability between middle and medial cuneiform and first and second metatarsal. The lateral rays are completely stable. If I can get this video to work, you can see that there's instability. It opens a little bit on the lateral side, but nothing that makes me overly concerned. So this is a standard open reduction fixation with a bridge plate. But then, so he returned to play at 4 months. But then he said, well, something happened during training camp. And if you look at it closely, the one screw is broken. There's clear widening of the Lisfranc space. So even this guy, even though this guy finished the season, he's heading towards a fusion because he has a poor result and is already developing arthritis. So even though he counts as a good result on paper initially, because he returned to play in the long run, is not a good result. This is the other side of the spectrum, which I think is even more difficult. This is a 21-year-old female basketball player. She had what they thought at the time was a grade 1 Lisfranc injury. X-rays were completely normal. And then 3 months later, she still couldn't really play. And then MRI was done that showed a near complete rupture of the Lisfranc ligament. And the fluoro, clearly it was now unstable. So at that point, an open reduction and fixation was done, clearly unstable. With the bridge plate, and went through the usual post-operative management. And then the hardware was removed 6 months later because she had time between seasons. You can see the one screw was broken and it had to be drilled out. So that maybe could have told me already that it's not as stable as what I thought it was. Returned to play again at 3 months, but she just never did well. So this is now almost 2 years out, well, 15 months out from what was thought to be a grade 1 Lisfranc injury, and she still cannot play. And there's clearly widening of the Lisfranc joint. So she ended up with a secondary fusion, and she's healed, but really questionable in the treatment. So would I have done it any different? Probably not, because I don't think you can legitimately claim that you should fuse all of those, but you have to know that some of them will not fail, will not do well. Question then is, do you use an internal brace for something like that? I've used it a few times. I'm not a big fan, but I'm sure some of the young guys will do better research on this and see if it's a worthwhile option in an isolated Lisfranc injury like that. Another one, college quarterback, fairly simple Lisfranc injury. On examination, it's not that simple. I always feel you have to examine all of these under fluoro to determine what type of fixation you will do. Did a bridge plate on him. The question is when to remove the hardware. The general rule is 4 to 6 months. When you remove it, you have to test them. You have to make sure that the cartilage looks good and test them under fluoro, make sure that it's stable. And the patient has to know that if it's unstable on the table, you will go ahead with a fusion. Because if it's unstable on the table and you remove the hardware, they're still going to be unstable. And that also begs the question, then some people say, well, don't remove the hardware. Now, if you do not remove the hardware after a Lisfranc open reduction fixation, it's essentially a fusion. So you're either a fuser or not. So if you don't take the hardware out, you're a closet fuser. So be a fuser or take it out. And it always reminds me of the inherent stability that you see. If you think about a hip dislocation, as long as you don't get AVN and you reduce the hip, that it's stable. The Lisfranc joints are completely flat, so they are not stable. So if you have a complete ligamentous injury, those ligaments at best is not as strong as the original. That's why you have a tendency to develop degenerative changes later on. So you have a dislocation like this. I don't think you can get them stable with an ligamentous repair with an open reduction. I think in those cases, they will do better with a fusion. Always think about the hip when you see this. So what about return to activity? We always hear the outcry that fusions are bad, but I don't think there's any evidence to show that fusions are necessarily bad, or if there is, you should show me that. But there's significant, I will go through a few papers here quickly, but again, you can look at this at your leisure after tonight's meeting. But there are several papers that show that severe injuries might do better with a primary fusion. This was a paper out of England showing that elite professional soccer and rugby players can go back to play. These were all treated with an open reduction fixation. The hardware was taken out at 4 months. Most of them returned to play. Soccer players got back a little bit earlier. And they concluded that the return to competitive elite level soccer and rugby is possible after surgically treated Lisfranc injuries. Another study out of the NFL that shows that 93% return to some level of play, median return to play 11 months. There was a slight decrease in performance. So that brings us to, for me, the most important part where we are now in history. There are hundreds of articles about Lisfranc open reduction fixation versus fusion or fusion, and you can quote the papers that you like to support your view, but that doesn't help the patient. We need to figure out what is the best for every individual. And I think the problem that we have with research on this is it's very difficult to have comparative data and testing, and outcomes questionnaires are limited at best to establish the true level of function. So if you want to read one article after tonight, read this one by Cochrane in 2017, Foot and Ankle International. This was in military personnel, 32 confirmed Lisfranc injuries, 14 had primary arthrodesis and 18 had an open reduction fixation. And the outcomes was returned to military duties. Now, the beauty of this paper is all of these patients had testings before. They're in the military. They have to do their fitness testing. And then they use the FARM score for outcomes. So return to full active duty for the primary arthrodesis group was 4.5 months. For the open reduction fixation group, 6.7 months, statistically significant. The fitness test 1 year later, with the primary arthrodesis group, they were 9 seconds per mile slower than before the injury. The open reduction fixation group, 39 seconds per mile slower. These are military people that I think if you're 39 seconds slower than the uninjured guy or 30 seconds slower than the fusion guy, you're going to be in harm's way at some point. So the FARM scores were the same. Implant removal is not important. So in conclusion, low energy, Lisfranc injuries treated with primary arthrodesis at a lower implant removal rate and earlier return to full military activity and better fitness scores at 1 year. So not all Lisfranc injuries are equal. Less severe injuries could be treated with an open reduction and fixation. And I think you should consider extra-articular fixation with bridge plating. Severe injuries, I strongly still believe limited fusions are better. We saw that recently at the NFL Combine, the guys with fusions had a higher likelihood of getting drafted. Also important, if you have a fairly rigid cavus foot, I'm less concerned about a limited fusion because they're already somewhat fused in reality. While if you have a very flexible flat foot, they might know a fusion more so than a cavus foot. And in these cases, you have to be very careful where you fuse them. Don't create an arch, make them as flat as the opposite side. And also remember that in the open reduction group, even if they do relatively well, a significant percentage of them will develop progressive degenerative changes over time. even though it might not be during their sporting career. And there's so far no hard literature evidence that a limited TMT fusion cause adjacent joint arthritis. And I will leave you with this. Have you ever regretted an open reduction of a bad Lisfranc dislocation? I for sure have, while I've never regretted a fusion. I hope you continue to debate this tonight, and I hope at some point in the near future we can do this in person and not over Zoom. Thank you very much for the invitation.
Thank you very much for joining us. Thank you for your reflections on your paper. It certainly was one of the game changers in Lisfranc fracture treatment. It was actually really quite an innovative study, because certainly when I was a registrar, you know, having been appointed only in 2005, everybody was just putting 3.5 mil cannulated screws across, you know, second, third TMT joints. How did you manage to get a randomized controls trial on what was in effect an innovative technique? Was it difficult?
So it's interesting, when I did my fellowship in '95 with Ted Hansen in Seattle, he was a very pragmatic guy, and he fused most of the Lisfranc injuries. And typical Hansen is, you know, I know this works, but somebody else will have to prove it. So he always challenged his registrars to go out and prove it. And it just so happened then when I joined the University of Minnesota, Mark Swankowski, who was the head of orthopedics in Seattle when I did my training, became head of orthopedics in Minnesota. So when I presented this idea to him to do a prospective randomized trial, I say, yeah, I know it works because Ted Hansen told me it works, so that's perfect. So he helped me steer it through the IRB.
Okay, so it was partly inspiration and partly serendipity, in a way that the right pieces came together at the right time and you could do it on that basis.
It's amazing how many important things happen because of circumstance, and this was one of those.
Absolutely. I suppose another question, with primarily ligamentous Lisfranc injuries, why do you think this subgroup often does badly compared to other groups within the fracture pattern, where the destruction appears worse? Is that your experience or not?
You know, this was the hardest part of getting this paper published, because when we tried to think how to plan it, Hansen's goal was you have to make this very clean, because you know how the people will look at it. If you say, well, there's a little bit of comminution at 2 or 3 and a fracture further down, they say, well, it's not apples to apples. So that's why we ended up just with almost pure dislocations, even though they are not that common. But I still, the only time where I feel it's very clear is if you have a very comminuted, disrupted Lisfranc joint. I don't think a lot of people will argue about those, that's better to fuse them right off the bat. But with these, where there's a little bit of fractures, but not bad, theoretically, you can treat them with an open reduction. You might also treat them with a fusion. This designation was purely just to have it apples to apples and not confuse the situation.
Okay. And was that why you also excluded ipsilateral ankle fusions and so forth?
Correct, yeah.
Okay, that makes sense. Why do you think the primary arthrodesis patients did better? Is it simply that the degeneration was inevitable, the writing was on the wall, and you were just preempting a fusion that was going to have to happen at some point?
Yes, and in the talk that I sent you, I made a few comments about the design of the study as well. If you think about it, at the time, all the fixation was transarticular screws. And theoretically, even though it's not totally proven, theoretically, if you put a 3-5 screw over the second TMT joint, you take about 20% of the joint surface. So you, in a sense, create degenerative changes. But I feel if you look at the Lisfranc joints, it's flat on flat, it's not a ball and socket. So if you have flat on flat and the ligaments are completely torn, and then you rely on scar tissue to make it stable, is less reliable than a deep socket and a ball if that dislocates. So my feeling is in a lot of these really dislocated Lisfranc injuries, even if you keep the screws or the plates over it for 6 months, the moment that you take them out, that scar tissue is not strong enough to maintain the normal stability of the joint, and over time they're going to get degenerative changes. And I think if you follow your patients long enough, you will see that is what happens in a fair percentage of them.
Yes, I think that may well be correct. Just out of interest, why do you think the patients that had primary fusion did better than those that had primary fixation and then subsequent fusion?
Oh, yes. I think it's less trauma for one. And that's one thing that I learned again with this is that primary fusion in the face of acute injury actually heals remarkably well, because there's a lot of hyperemia and healing responses. So it makes it easy for the bone to heal, and then it's done. If you wait for secondary fusions, there's a lot of scar tissue. There's usually a deformity that you have to correct. And now you have fairly sclerotic bones on both sides of the joint, while at the acute injury, it's very well vascularized subchondral bone. So the bone healing is just much more predictable at the primary than the secondary. Because I still maintain, after 25 years doing foot and ankle, the most difficult fusion is to correct a severely deformed midfoot collapse. So if it's that chronic Lisfranc injury that's in 30 degrees valgus and 20 degrees extension, to get that aligned and fused is a hard procedure, because you end up with a short first metatarsal, and it's hard to get your plantar flexion and three-dimensional position correct, while if you do it acutely, it's very simple.
Yes, I mean, a midfoot fusion post-Lis Franc for gross deformity is certainly not an operation that one skips into the theatre hoping to enjoy. Certainly, I agree with that. So in a sense, what you're saying is the biology is more favourable on the first hit than going back second.
Absolutely.
Time. Yeah, well, that certainly makes sense.
You know, if you think about fusions, if you have a Saunders 4 calcaneal fracture, and the debate is whether you do a open reduction fixation and primary fusion at the same time, or do that fusion 3 or 4 years later. The fusion rate is higher, and it's much easier primarily, and it's because the biology is in your favor.
Yeah, which is something we all like to have on our side, certainly. Have you experimented at all with extra articulate bridging plates and so forth, or is that not part of your standard repertoire?
100%. The last time that I put a transarticular screw for a Lisfranc is probably 6 or 7 years ago. Again, that was not part of what we did in 2005. But I think for if you do an open reduction fixation, I strongly believe now it should be a bridge plate, even though there's not really good literature to support that. But it just makes sense to me that transarticular is better. I still do the syndesmosis, the Lisfranc screw from medial cuneiform to second metatarsal, but all the other fixation is bridge plating.
Yes, I mean, it's certainly if one's trying to preserve what is a relatively small joint, the idea that you drive a 3.5mm screw through it is clearly tantamount to asking for arthritis, isn't it? At some future point. So therefore, you think the fixation of medial to middle cuneiform is still important as part of this, and do you routinely incorporate that in your fusions when you do them, or is that just a single screw to stabilize it?
When I fuse it, I still prepare the interval between medial and middle cuneiform and base of second metatarsal and medial cuneiform as if I wanted to fuse. If it fuses, that's great. If it doesn't fuse and there's just a strong non-union, I think the result is the same as long as you get first tarsometatarsal and second tarsometatarsal to fuse.
Yeah, okay, fine. In your original paper, perhaps unsurprisingly, there were not a large number of elite athletes or high-level sportsmen. What would be your approach to, I see you have a Viking stadium behind you, I think, by the look of it. What would be your approach if one of the Vikings came in with a Lis Franc injury of this type? Would you go for a primary fusion?
That's a great question, and a question that I get asked all the time, because for better or worse, I still see a lot of Lis Franc injuries. And for me, the approach is exactly the same. If it's not a completely unstable injury, oftentimes, especially in football, we see these longitudinal Lis Francs. So it's an instability between medial and middle cuneiform, first and second metatarsal, and everything else is intact. Those, I don't think you need to fuse primarily. That's a ligamentous injury that can usually heal. So those I will treat with an open reduction fixation. If it's one that I feel one can treat without a fusion, I will. But I have no issue fusing an 18, 20, 22, 24, 26-year-old professional or high school athletes if I believe it's the right procedure for them. And we are in the works now of actually showing that I personally have about 20 now where I did open reduction and fixation in high school, college, professional athletes that I had to take back a few years later to fuse. So if I fused them right off the bat, they would have played much better and with less compromise on their career. Okay. But again, I don't fuse everybody. I fuse the one that I feel need a fusion.
And on the overall picture of all the Lis Francs that you see, roughly what sort of proportion is that? Ballpark.
I fuse, what did we say? I fuse about 60% of them primarily in athletes.
And in non-athletes?
So if it's a motor vehicle accident, I have even a lower threshold to fuse them, because most of the level 1 trauma injuries have comminuted fractures as part of the deal, and that's very simple.
Yeah,
I want to treat them once and get it over with.
So it's not exactly your go-to, but it's probably your most common method of treatment for these kind of injuries.
Yes, for level 1 trauma, probably 80% of cases.
Okay. For
sports injuries, you have to individualize.
Okay, of course. And what do you think is technically the most difficult aspect of a primary fusion?
So the most difficult part of a primary arthrodesis, and these ones that are dislocated, is to make sure that your three-dimensional alignment and reduction is correct. So I actually prep out both legs, because there's a big difference in where you position the foot in somebody that has a cavus foot versus a flat foot deformity. And I really think a percentage of these that get primary fusions that do not do well is because you fuse them in a different alignment or inclination than the opposite foot. And where I really see that is if you have somebody that are flat-footed, like a lot of the athletes are, if you fuse them in cavus, in a 4-foot cavus, they dislike it like the devil, because it's completely different and they know they are fused.
Presumably because it's a more rigid foot pattern anyway. So,
correct,
so you've taken something flexible and not only fused it, but you've actually moved it into a far more rigid platform. Okay, yes, that makes perfect sense. Any tips and tricks you would offer to our members seeking to undertake primary fusion for these type of injuries?
Don't use a saw. Don't use a saw to create osteotomies, because most of these most of the bone anatomy is still there. So just scrape cartilage off and expose subchondral bone either with a small osteotome or a drill so that your anatomy is preserved. And then the second thing, it's no different than if you do a Lapidus procedure. You have to make sure that you have rotational correction. So when you think you have your first ray in the right position, fix it with a K-wire or two, and then do a sesamoid view. So an axial view from the front of your foot to make sure that your sesamoid rotation is correct. You don't want your first ray to be pronated. That's the most common deformity, or even supinated. So if your sesamoid alignment is correct and your inclination talus to first metatarsal is correct, the same as the opposite side, then you can put your plate on the medial column. And once your medial column is fixed, then the others you basically just line up with the first ray.
Chris, that's really helpful. I have, before we go, one final question actually sent in by Andy Goldberg from London, who wants to know, Chris, is it true that President Biden spends much of his time asleep with a small dog on his lap?
Why did I'm not surprised about that question. I don't know. I know Biden has a big dog. I don't know if they have a new dog as well, but one of the two will be asleep.
I'm sure Andy will be delighted to know. Chris, thank you very much. You've been very kind to share your time with us. Hopefully we'll have all this recorded, not need to bother you any further. But on behalf of both the Scientific and Education Committees of BOFAS, thank you very much for sharing your expertise.
Yeah, thanks a lot. Have a good evening.
Thank you, Alisdair Felstead, for presenting that paper, and Dr. Chris Coetzee for his reflections, and Mr. James Ritchie for questioning Dr. Coetzee on this landmark, often quoted study. The quote at the top for me was that if you don't take the hardware out, you are a closet fuser. So be a fuser or take it out. But some important points otherwise were to fix the less severe ones, fuse the more severe ones, and use fluoroscopy to help in between. Beware of instability at the point of removal of metalwork. So we've already heard of Dr. Coetzee's preference of bridge plates over screws when he's fixing or fusing Lis Franc injuries. And our second paper is actually concentrating on exactly that somewhat controversial topic. Dr. Ariane Tutsch, who is a foot and ankle fellow at the Nuffield Orthopedic Center in Oxford, will be presenting our second paper.
My name is Ariane Tutsch. I'm a clinical fellow, foot and ankle at the Nuffield Orthopedic Center in Oxford. Today I'm going to do a recording for a paper for the dorsal bridge plating versus transarticular screw fixation for Lis Franc injuries, a systemic review and meta-analysis. Published in the Journal of Clinical Orthopedics and Trauma in April 2020. With the key authors Kailash Boksh, Ashwini Sharma, Douglas Grindley, Pip Diva, Jitendra Mangwani from the Department of Trauma and Orthopedics, Leicester Royal Infirmary, and Center of Evidence-Based Hand Surgery, the University of Nottingham, both in the UK. Lis Franc injuries are relatively uncommon, but carry devastating consequences if left untreated. There have been many surgical techniques proposed for the best operative management, and there is an ongoing debate over which procedure is superior. There's different disadvantages or critics in transarticular screw fixation. What has been the main surgical and traditional technique? Like articular disruption, metalwork breakage, failure of fracture compression, and refracture through screw hole upon its removal. Cadaveric studies have shown dorsal bridge plates have a more favorable biomechanical construct, avoiding penetration of articular surface, and can be extra-articular placed and bypassing comminuted fractures. Therefore, they can't be placed percutaneously and increase the risk of soft tissue, neurovascular damage, and wound leakage. Therefore, exists a controversy which technique is the best to treat Lis-Franc injuries. The goals of treatment to achieve a painless plantigrade stable foot with return to premorbid function. Suboptimal treatments can lead to chronic pain, flat foot deformity, residual ligament instability associated with soft tissue injuries. Therefore, the objective was to perform a systematic review and meta-analysis to investigate the outcomes between dorsal bridge plating, the intervention, and transarticular screw fixation, the comparator. The following databases were searched: Ovid Medline, Ovid Embase, Cochrane Central Register of Controlled Trials for randomized control studies, cohort studies, with the eligibility criteria for all RCTs and cohort studies that compare transarticular screw fixation and dorsal bridge plating of Lis-Franc injuries in patients over 18 years. Therefore, 1 prospective cohort and 3 retrospective studies were identified with a total number of 210 patients, mean follow-up 14.6 months, where 93 patients underwent transarticular screw fixation and 117 receiving dorsal bridge plating. All papers were analyzed of quality and reporting according to the standards of PRISMA. This is a small picture how the studies were selected. The PRISMA flow diagram also shown in the paper. The outcome measures were postoperative infection rate, AOFAS score, FFI score, post-traumatic arthritis, failure of hardware material. The results show dorsal bridge plating is associated with better AOFAS score compared with transarticular screw fixation. Dorsal bridge plating might also be associated with fewer cases of arthritis, although it was not significant. And there was no significance showing with regards to foot FFIE, post-traumatic arthritis, failure of hardware material, and post-operative infection. Also, the results suggest dorsal bridge plating might provide superior functional outcomes. There's a scarcity of the literature to make definite conclusions. Therefore, high-quality randomized trials are required. In the papers, the main limitation was a small number of patients. The studies were all non-RCTs, and there was a high level of heterogeneity amongst the studies. Therefore, an appropriately powered randomized controlled trials required to determine whether the lack of significance difference for some outcomes is true, and a recently registered RCT is aiming to compare such clinical outcomes between the 2 treatment modalities over a 1-year period. Such results currently awaiting their help in defining the desired treatment option. The conclusions: transarticular screw fixation is a traditional method of Lis-Franc fracture fixation. Dorsal bridge plating has shown in cadaveric studies that it's a superior biomedical construct. 4 low to moderate quality studies were included in this paper. The findings suggest dorsal bridge plating may lead to superior AOFAS scores, yet there is a high level of heterogeneity and high quality randomized controlled trials are required. Thank you very much.
Thank you, Ariane, for your excellent presentation. Now I would like to present the senior author on this paper, Mr. Jit Mangwani from University Hospitals of Leicester, who besides this paper is extensively published. He leads the BOFAS James Lind Alliance Priority Setting Partnership Project, and having been on the BOFAS Scientific Committee since 2017, he is currently its chair. Please remember that if you have any questions, can you please use your Q&A button and we will deal with them afterwards.
Great. Thank you, Togay, and thank you, James and Togay. It's been a really interesting session so far, and thank you for asking me to share my reflections as a senior author on this paper, which are essentially on two lines. One is around the need and the timing of this systematic review, and I'll talk about that. And the other one is around, just like Chris has had experience and some evolution in practice and understanding of this Franc injuries. So how this systematic review came about is after the study that was published in the BJJ in 2018, comparing dorsal bridge plating versus the transarticular screws. We started sort of looking into it in our unit and seeing, because everybody had seen that change in practice without really experiencing or coming across a huge amount of data supporting one way or the other. So that particular study was a retrospective one, and a conclusion was that dorsal plating was doing better in patient-reported outcomes. And if you bolt it too much in terms of columns, then you're going to have a lower patient-reported outcome in that. So around the same time, we'd applied for a grant for a biomechanical study to look at more physiological, more biological kind of alternatives of fixation. And this is how this all came about. So we started looking into the published literature and synthesizing it. And as you just heard, at the time, there were only 4 papers that were eligible for inclusion in the systematic review and meta-analysis. And of those 4, 3 were retrospective comparative studies. So the quality of the published literature wasn't at level 1. Interestingly, the change in practice had already happened. So we all, just like most of you are online, would have moved from transarticular screws to dorsal bridge plating at some point with the advent of the newer metalwork that was available and pre-contoured plates, etc., providing better stability and supplemented by mechanical work that was certainly in line with better stability initially. So these studies had looked at the domains that we were interested in, particularly around the infection, around the patient-reported outcomes, but they had a degree of heterogeneity, as you saw, and in their patient selection, in their outcome measures, and a potential for bias, which we obviously acknowledge in the systematic review. And just like with a lot of systematic reviews, unfortunately, if your data entry point is where your data level of evidence isn't at level 1, you're not going to suddenly come out at a level 1 evidence based on the systematic review only. The 2 significant findings that we looked at were around the AOFAS scores were better in plating group compared to the screws that we just heard. And also there were fewer cases of arthritis, and Chris alluded to earlier on in his discussion about whether you put a transarticular screw and damage the cartilage, in addition to the original injury or the index injury, which has already damaged the cartilage and the blood supply around there. So as for the evolution in my practice and some observations, I think one of the things that I must say we're seeing less of is missed injuries. And that's a good thing in this Franc. Certainly, when I was SHO registrar level, we used to quote 20%, i.e. 1 in 5 could be missed through ED. And that could be through virtual fracture clinics, could be through the education that's gone out there from various people, and early foot and ankle specialist input, certainly in our unit, and I'm sure it's shared by other units as well, that there's much less threshold now for a specialist to get involved at an early stage. One of the other things I think Chris is pointed out with his video, intro video on EUA, I think it applies to both settings, both for the outpatients as well as the EUA. And the ones that you look at and think, are they really stable or not stable? How are we going to find out? And once the patient is at a stage of bearing a little bit of discomfort pain, usually a week, 10 days down the line, it is a good idea to do a weight-bearing radiograph, compare with the other side with the identical view to make sure that you're not missing out on those subtle unstable ones. And I think that's certainly embedded in my practice. I can't emphasize enough the need for the EUA. I do not put knife to skin before I've done that and assessed both for the TMT instability and as for the intercuneiform instability too. So I think one has to be very careful designing where you're going to be putting your incisions, having adequate soft tissue bridge. And the timing of surgery, as we all know with this particular injury, as like anywhere else in the foot and ankle trauma, is crucial. You've got to get the timing right, and waiting for a bit is absolutely fine as long as the joints are not completely dislocated and your soft tissue resuscitation is en route. And anatomical reduction, I think there's again evidence around it. Reduce these injuries anatomically and make them stable enough so that we can think of early rehabilitation. And that's another thing which has progressed over the years in everybody's practice, particularly in my practice too, that I would start, even if I don't weight bear them at 2 weeks, certainly an early range of movement in their foot and ankle is going to help them keep their movement and the lower limb function much better. And the other thing is around the pain management. I think a lot of these injuries, when they're very severe, they have that sort of neuropathic, early complex regional pain type picture, which unfortunately gets missed a lot of times. And I'm super, paranoid about it, if you like, and I want to assess that right at the beginning, whether there's any damage to the superficial peroneal or the peroneal area. And at the time of surgery as well, you've got to be really looking for that neurovascular bundle as you're approaching in between the first and second, and have a low threshold of putting these patients on some neuropathic painkillers early on, because it certainly helps calm things down for them. So I'll stop there. Those are the reflections from my side, and Togay can take over if there are any questions.
Thank you very much, Jit, for your reflections and also in a general summary of the literature up to now. So we'll start taking some questions. So please post them through the Q&A section. And because there's no questions yet, I'm going to take advantage to ask some questions of my own, if that's okay. So it seems like systematic reviews and meta-analyses are coming up in every journal that I get through the post, or they're really frequent. It's not uncommon for some of them to use almost the same papers and come up with different results on occasion. So how do we ensure that when we're looking at these, when we're analyzing the evidence, that we're looking at a good systematic review? So what makes a good one? What makes a poor one?
Yeah, no, that's a great question, Togay, and I think it's important to assess the literature very critically. And as you say, there's almost like a fashion or trend sometimes of systematic reviews or meta-analysis on particular subjects. So I think you need to define your research question very well. You need to establish certain inclusion-exclusion criteria right at the beginning, write the whole protocol, and do not change it once you've gone through your versions 1, 2, 3, 4 and accept it as a group. It is a teamwork. It isn't about one person doing a systematic review, and the team should really be involving a clinical librarian or somebody who works in the evidence base. For example, in this paper, you will see Pip is a clinical librarian, and Douglas actually is the person who sends all these foot and ankle update systematic reviews to us all the time. We used to up until last few months. And I think it's important to do that. And then you register that systematic review through Prospero registration. So if there's somebody else is doing it, there's no point duplicating that work. You find that out right at the beginning. And also, once you've done that, once you've done all of that, there are now tools available that you can use online to extract the data, to make it absolutely foolproof and be totally independent of each other. Two independent assessors are assessing this, then you can be totally independent of each other and not sit down in a room and do it together and and sort of confound some of those ideas from each other. So I think it's important that we follow that, and the write-up has to be in line with what the PRISMA guidance is, and it's important to follow that as well.
Thank you very much. One concept that sometimes is confusing, and you found in your systematic review about the AOFAS score being particularly different, the only one that has a statistically significant difference, but it had high heterogeneity. What does that mean when we're looking at systematic reviews?
Yeah, no, absolutely. I think there's that risk of bias and heterogeneity, so you need to take into account, and there are obviously now softwares that you can use, and Cochrane has one of those as well, so you need to be familiar with that when you are assessing these papers, and not come to the conclusion which is different to what it should be. And also, I think that if I can add, assessing the quality of the papers, there are ways around modified Coleman, and we've used Newcastle Ottawa here for the cohort studies, but the most commonly used will be a modified Coleman, which I've done previously with other papers. So I think being familiar with those is important, and using them to assess the quality of the data published already, so that you can give, when you are writing that up, you give a true account of what the literature is saying. Okay.
Thank you very much. We're still waiting for questions from the audience. If there are any, please put them in the Q&A section. Did the research you did change your practice, or were you, and what method do you use for fixing these?
Say again, sorry, I missed the early bit.
Did your research change your particular practice, and how do you fix these? Do you use transarticular plates or screws?
No, so like most of us who moved with times into plates over the years, I don't think in 5-7 years that I can think of I've ever used a transarticular screw. These are all bridge plates. What was interesting is what Chris said in his discussions is the number of patients that he's fusing. I don't think we're anywhere near that number of TMT fusions that we do for Lis Francs. Certainly for multi-fragmented, comminuted ones, they go under fusion. And I think his numbers are certainly way above than what average there will be in our unit. And I'll be interested to know people who are online to see if they have a similar sort of experience. The other thing is around metalwork removal. So when you put this metalwork in, clearly I think with the, as he said, if you're a closet fuser or not, you're not at the beginning, but inadvertently you tend to be towards the end, because patients gone through a big injury and they further fixation, rehab through, and they're about 6 months or 4.5, 5 months, 6 months when they feel that the foot is now doing really well. And that is the time you ask for them to come back in and do another operation and take the metalwork out. So you have that informed discussion in a shared care model with a patient, and patient goes, I really do not want anything done at this stage. If something snaps in the future, I'll come back to you. I don't know what your experience is and others' experiences around there. Mine is certainly around there. But anecdotally, when you take the metalwork out, particularly the sporty ones that I've done, and you take the metalwork out, they do feel that there's a little bit more play in their foot, and they feel better. And I've not, the other thing I've not had is a huge amount of recurrent instability after metalwork removal.
So do you routinely remove metalwork?
I'd have a discussion with the patient, but vast majority actually do not choose to have the metalwork removed. And it's only when sometimes they will have the screw snap and the plate becomes prominent is the time that they come for metalwork removal.
Thank you very much. So we have a question from George Smith. In your review, Jit, you recommend further high-quality randomized trials. what particular clinical questions concerning this injury, investigation, or fixation choice would you most like seen answered?
Yeah, that's a great question, George. So I think the more pressing question for me is the fusion versus fixation with metalwork removal. And I don't think with the modern metalwork that we've got in the last 5-7 years, it's Chris Coetzee's study expanded with the bridging plates, as well as going for fusion for more wider group of patients rather than just the pure ligamentous one that he'd done in 2005-6. So I think that is a study that will be worth undertaking and will give us some decent answers.
So off of that, I guess my question to you would be, if we want a high quality randomized study, and given that this is a relatively less commonly occurring injury, what would that trial look like to you? How would we set that up?
I think it'll have to be definitely a multi-center NIHR type funded study rather than a localized sort of one center or a few center study, because as you said, the numbers are not that big in this study, in this patient group, as well as the numbers you have. Not everybody is going to be eligible and be ready to be part of the study, so it'll have to be a big NIHR funded study.
Great. I think we've run out of time. Thank you very much for answering those questions. And on behalf of BOFAS, we'd all like to thank our sponsors for this evening's talk, DJO, all of our speakers tonight for their valuable contributions, and of course, all of you, our attendees, for attending tonight. I hope you enjoyed this evening's Journal Club as much as I did. And the next one is on the 18th of November with a couple of papers on the hindfoot. Mr. Karen Malhotra from the Royal National Orthopaedic Hospital in Stanmore has just put the feedback code, as he's on the BOFAS committee. He's been working hard in the background to make sure tonight goes smoothly in the chat. If you follow this, follow the link and or the QR code that will be displayed imminently on screen and put in that feedback code, you can fill out the feedback form and you will get your certificate of attendance for CPD points. I'd like to wish you all a good night and thank you very much for attending.